So everyone, welcome to our webinar on strategies to manage rising healthcare costs. This is the first event by Scaling Nonprofits in our fall series about advising nonprofits on the challenges they are facing. I'm your moderator, John Gillespie. This event is produced by my partner, Kim Bulger, and me. We are co-founders of Scaling Nonprofits. Our speaker today is Ken Campbell, Senior Vice President at Hub International, where he leads a team delivering innovative, integrated health and benefit solutions. With over 30 years of experience, Kent specializes in helping nonprofits navigate the complexity of today's healthcare and insurance landscape. He partners with organizations to control cost, ensure compliance, streamline HR, and benefits administration, and he designs market competitive programs that improve employee health and satisfaction. Kent and I first worked together from 2014 to 2017 when I was the CFO at a $30 million nonprofit. Ken, thanks for being on the webinar, and I'll turn it over to you.
Hey, thanks very much, John. Pleasure to be here, and thanks to all of you for attending this webinar. Again, my name is Kent Campbell. As a health and benefits advisor, my Hub team and I have been working side by side with employers of different sizes, industries, geographies, cultures, and needs for 30 plus years. But I have to say, I have a special affinity for and focus on serving nonprofits. Having worked with elder care service agencies, schools, a hospital that treats children with special needs, health and human service organizations who help disabled individuals, museums, or institutions that protect our environments, I've seen firsthand the special work nonprofits do, how much they care about their employees, and the mounting challenges they face. One of those critical challenges is the topic of our presentation today: how to continue to offer the most quality and affordable plan to your employees that fits your budget. To address this question, we will first talk about the perfect storm, or the convergence of factors that are leading to historically high healthcare costs, which are impacting all stakeholders, from carriers, healthcare providers, and importantly you, nonprofits, in the form of escalating health insurance premiums. Next, we'll focus on strategies to manage rising health plan costs in context to A, traditional group health plans, and B, in context to relatively new alternative health insurance models. Next, we'll discuss the importance of having a year-round planning process to manage your health plan and scope out possible solutions to minimize costs and optimize benefits for your employees. Lastly, we'd like to reserve some time to have a Q&A section, at which time we certainly encourage any feedback, questions, need for additional information. So as this slide kind of points to, and to state the obvious, the root cause of escalating health insurance premiums is increasing healthcare costs. As the PwC chart on the left-hand side of this page shows, we have lived with increasing healthcare costs ad nauseum for many years, dating back to 2007, as shown here. With that said, we had a relative dip in healthcare cost increases pre-COVID to see increases roaring back to post-COVID in 2023 and after. To the extent that this is estimated to be U.S. expenditures of $5.3 trillion, which reflects 8.2% increase over 2023. As for 2024, national expenditures are expected to be about 18% of gross national product. Further, 27% of all federal spending was directed towards public health programs, namely Medicare and Medicaid. Unfortunately, as PwC and others have stated, there does not appear to be any end in sight, as is kind of graphically portrayed with that arrow continuing to go up, as was featured in an article as recently as September 10th from Wall Street Journal, citing a 9.5% projected increase for 2026. Now, there are many drivers that are increasing healthcare and insurance costs. Many are actually summarized on this page. We could spend the rest of the day kind of discussing these, but for purpose, interest of time, I'll just kind of walk through some of the highlights on this slide. On the supply side or healthcare delivery side, we're seeing unit cost of healthcare treatment increase due to just general inflation, which has an impact on increasing wages, which is compounded by labor shortages, especially with PCP and behavioral health providers. We're also seeing the continuation of consolidation of the already huge health systems who use their market might to fight for higher reimbursements from carriers. High prescription drugs is also a culprit, as manifested in particular as of recent by the impact of GLP-1s used for diabetics, weight loss, and other emerging medical conditions. While the specialty drugs compose about 2.2% of all prescriptions, they are responsible for 50 to 55% of the total healthcare prescription drug spend. Yesterday, I was on a nonprofit in a nonprofit meeting down in DC, who's faced with, for example, a $400,000 prescription drug for one young dependent who has issues as it relates to absorption of nutrients within their bowel. This is a prescription drug that is increasing her health span as well as lifespan, as are same for drug therapies for cystic fibrosis and other rare diseases, which again, miraculously are enhancing people's lives as well as lifespan. Other factors here, obviously, increased utilization of healthcare services and drugs due to deteriorating health caused by the aging of the workforce, lifestyles, etc. And there's also a spate of regulations of which I could spend the rest of the day also citing, but one in particular of which I suspect is painfully apparent to a lot of nonprofits that we work with day to day is a so-called Big Beautiful Bill, and a lot of which is still to be seen as far as what kind of impact it's going to have on the health insurance market and the costs, and ultimately what employers pay. But suffice it to say that if the ACA subsidies expire 1/1/26, that could result in the current number of 21 million some people that are currently covered under the ACA health insurance market / public or private exchange is going to be reduced significantly, which could in turn result in us going back, at least in part, of reduced number of insureds or an increased number of insureds, which could result in delayed care, spikes in emergency room usage, and costs that could be cost shifted to the private market. Some of these, the spikes in health insurance, or rather healthcare costs, has even caught health insurance carriers off guard, to the extent that Blue Cross Blue Shield of Massachusetts and Harvard Pilgrim are facing historical financial challenges. As this slide shows, Blue Cross Blue Shield and Harvard Pilgrim have lost $96 million and $173 million already during the first 6 months of 2026. This is in the wake of each losing $400 million and $382 million respectively in 2024. Each carrier cites the unprecedented increase in medical as well as prescription drug utilization and costs. And in particular, they're citing the spike in GLP-1 usage for weight loss, of which each carrier, kind of in contrast to the national for-profit companies like a UHC or a Cigna or an Aetna, they had decided, Blue Cross Blue Shield and Harvard Pilgrim, that is, to cover GLP-1s for weight loss for 2024. As we'll kind of get into later in the deck, they have decided to cease covering those drugs for all groups under 100 employees, as is the case for Mass General Brigham Health Plan, effective for renewal date, some of them January 1 or after. As a result of these losses, they've also felt the pain of having to lay off employees and or just as reported last week by Blue Cross Blue Shield, offering 700 some people voluntary buyouts. As benefit advisors, we have seen spikes in renewals and carriers being less receptive to renewal negotiations, which has created a fair bit of angst that, at least personally, I feel on behalf of my clients and having to be faced with, managing the best outcome given these circumstances to best meet the needs of nonprofits as well as their employees. These spikes in healthcare costs not only affect the payers, i.e., Blue Cross Blue Shield, Harvard Pilgrim, etc., but they've also impacted the health systems within Massachusetts, which, as an aside, everything I've kind of talked about here is, I know, is focusing on Massachusetts, but serves as a kind of microcosm to what's going on in the other New England states, and for that matter, the rest of America. But based off of the most recent CHIA report, Center for Health Insurance and Analysis, which is an agency within Massachusetts, that more than 50% of all hospitals are operating in the red as of the end of 2024, and actually continue to encounter financial struggles into 2025 to the extent that Governor Healy signed a bill providing a critical funding for hospitals and community health centers to the tune of $234 million. And you can see how that $234 million is translates by different category of health service provider. So in the face of, like I said in the previous slide, of a good many of health systems, hospitals facing financial struggles, it's a bit of a tale of two cities, because on one end of the spectrum, you're having a lot of hospitals really being severely challenged, while on the other side of the spectrum, you have the financially healed health institutions that are investing literally $1 billion+ into expansionary plans, which, in turn, obviously result in that much more in the way of delivering the state-of-the-art healthcare for the patients of the Commonwealth. With that said, that does not come without cost increases, of which no doubt we will, continue to see as manifested in insurance premiums going forward. But I know driving into Boston, in certain areas, you see a lot of construction where these new sites are going to be going. $1.9 billion investment on the part of Mass General, $1 billion on the part of Beth Israel to borrow $1.1 billion for a new cancer hospital. So these tensions or these financial struggles that the health insurance companies are contending with, on behalf of their plan sponsors and employees, as far as their goal to deliver health insurance premium renewals that are going to be affordable, while at the same time kind of optimizing benefits for the employees. On the other side of the equation, right, are these health carrier, or rather health systems, that are wanting to extract as much in the way of reimbursements as possible. And so therein lies the rub, as kind of manifested by this 11th hour deal that Point32 Health and Tenet struck. And Tenet is basically a health system that includes St. Vincent Hospital, Metro West Medical Center, and Framingham Union Hospital, and Leonard Morse Hospital. All hospitals or health facilities that are located in central Massachusetts. But the point being here is that obviously Tenet was trying to extract as much in the way of higher reimbursements from Point32, and Point32 was trying to extract as lower reimbursements or relatively lower reimbursements so that they could keep their premiums down. And we're seeing this not only here in Massachusetts, but across the country where payers, insurance companies, as well as deliverers of care are constantly at loggerheads at levels that we have not seen in the past, to the extent that sometimes you'll actually just outright see the payers and the deliverers of care agreeing to disagree, and certain providers dropping from the market, which is evidenced by what MGB, Mass General Brigham, did in leaving some of the Medicare Advantage primary care networks, affecting 19,000 some patients. Now I know that pertains to retirement plan, insurances, but suffice to say is that, that this is a dynamic that's occurring in the marketplace. These large increases are also impacting here in Massachusetts, an unprecedented increase request on the part of these insurance carriers that are not only offering their policies on the individual market, the ACA market, but also to small group employers. In general, the increases that were requested by these carriers that were submitted to the Division of Insurance came in at levels that were ultimately approved by Mass Division of Insurance that were 5 percentage points higher than last year. So suffice to say, effective 1/1/26, 420,000 members are going to be impacted by these increases. As it relates to groups over 50 employees, in the event, employers experience an 89% loss ratio, which is the target loss ratio that carriers are look to basically break even and maintain enough for some profits, even though they're nonprofits. They also have to have reserve requirements they have to satisfy. Even if a client is at an 89% target loss ratio, i.e. claims versus premium, there would expect what we call a trend increase of +8% to +12%, referencing back to that Wall Street Journal trend article. And it kind of put it into real life perspective, and this would be the worst case scenario that I personally am dealing with right now. 134 employee group with 120% loss ratios receiving a 49% increase. We've received increases. Hub is the largest insurance brokerage firm in Massachusetts, if not also in New England. We have teams of people like myself that are constantly receiving renewals from the various carriers, and it doesn't matter if it's a nonprofit or a for-profit carrier. We're seeing renewals anywhere from, on the best of occasions, 5% to the worst of, I've heard others getting 60-something% increases. Just as an aside, carriers are adding 4 to 6% to renewal premiums if clients want to continue to retain coverage for GLP-1s for weight loss. Some of the carriers, actually United, Cigna, and Aetna, just outrightly don't even offer coverage for GLP-1s for weight loss unless they're larger and self-funded, because the risk is transferred onto the employer. So I've been talking a lot about the dynamics of the market and its impact on healthcare costs, which translate into health insurance premiums. So what are the areas that we can that we find ourselves working with clients to kind of just best manage those cost increases. And I have to preface, these solutions or strategies that I'll be citing, that, their appropriateness of adoption is going to obviously depend upon the specific characteristics, circumstances, culture, and objectives specific to each nonprofit institution. So what I'm going to explain here is, provide you a summary of at least those strategies that are available in the marketplace to provide a general understanding for you of what options are available. And I'm going to do so in context to traditional group health plan or insurance strategies, group carriers, versus in the succeeding page, we'll also get into strategies in context to what I'm characterizing as alternative, relatively newer health insurance models. So first off, as it relates to, strategies specific to group health plans, we have our traditional, standard approach as benefit advisors have obviously working in concert with our clients to conduct the comprehensive market reviews versus, what we call the no bid strategy in exchange for lower renewals, whereby we get an initial renewal from the given carrier. We talk that through with our client and, talk through the pros and cons of whether or not we should be going back to the health insurance carrier to ask if they're willing to lower the rates in exchange for not going out to the market. And there are various circumstances there that we would want to consider with the client as to whether or not it makes sense to pursue a comprehensive market review or the no bid strategy. Secondly, carrier negotiations obviously is huge as far as what we find as far as our ability to extract best rates as possible from a given carrier, especially if they're over 50 employees in the state of Massachusetts, which means that their claims experience does come into play. Whereas for 50 and below, the rates are the rates because they're filed and approved by the Division of Insurance and they're non-negotiable. But with a larger group, especially if they're over 100 employees, we have access to the claims experience, we have access to their renewal formulas, of which, I had the good fortune of working side by side, our Hub's in-house underwriting team that come from Blue Cross Blue Shield and other carriers. And so they know the ins and outs of how renewals can best be negotiated by contesting certain cost components of the renewal. We also get into evaluating on a traditional basis, whether it's an HMO versus PPO versus open access versus tiered network versus limited networks. Suffice it to say, depending upon where the employer is located, market-wise, what state and what carriers are available to them, there could be a whole spectrum of different types of health insurance products, provider networks that we will evaluate on behalf of and clients would be evaluate. Health plan design, obviously, with as we saw on one of the preliminary slides there's been kind of this perennial, eternal increase in healthcare costs, and no surprise over that period of time, employers increasingly more are having to cost shift to their employees, increasing the co-pays, the co-insurance, and the deductibles, considering high deductible account-based plans that are coupled with the health reimbursements, the medical expense reimbursements plans, the HSAs, looking at broad versus narrow RX drug formulas, etc. Also, as a result, as a part of evaluating different strategies, especially if a group is of a size that could consider partially self-funded arrangements. Clients certainly have that as another lever to pull to make sure that they are with a funding program or a type of funding arrangement that is going to maximize cost efficiencies. So therein lies the opportunity to conduct a comparative financial review between an insured arrangement, a level funding arrangement, and a self-funded arrangement. Later on in the deck, we will kind of dive a little deeper into alternative plan design strategies, as well as health plan funding strategies. Also in context to, again, traditional group health plan strategies, there's a lot more being done on the part of employers to get creative as it relates to modifying employer versus employee premium contributions. Maybe it's salary based, maybe there's a defined contribution that applies, i.e., an employer is locking in the calculating a premium contribution towards the lowest base plan among 2, 3, 4 plans that may be offered by the employer to the employees, such that if employees decide to go to a more generous plan, they have a buy-up. I know there's a lot of this is standard fare, but we have found for the most part, and I'm basing it off of recent, the last year or 2, 3 years of my experience in helping nonprofits, that we've been successful in modifying or getting that health insurer to come down on the rates through carrier negotiations, through health plan designs, through health plan funding, and through employer versus employee premium contribution modeling, and bringing into the fore our in-house underwriters, the contest renewals. There's also certainly greater adoption on the part of employers to consider dependent eligibility verification audits. In fact, I have a large health and human service organization that recently did that and was successful to the extent that they found that there were quite a few spouses as well as children that did not meet the definition of spouses as well as dependents. The same health and human service organization employed a spousal surcharge to the extent that in the event you have an employee with a spouse who's eligible under his or her own employer's group health plan, continues coverage under the employee's employer's health insurance program, that employer would apply an additional $150 to $350 per month extra premium. There's also this is a relatively new strategy where you have spousal incentive health reimbursement arrangements or employee incentive health reimbursement arrangements, whereby an employer sets up a special health reimbursement arrangement on behalf of employees who decide to migrate from the employer's health insurance plan and go onto the spouse's plan. So not only the spouse, but also the employee of the nonprofit, as well as the dependents, children of the employees of the nonprofit, migrate to the spouse's health plan. And they're incented to do such by virtue of the fact that any deductible out of pocket that is incurred by under the spouse's plan on the part of the employees and the children would be reimbursed by the employee's employer's plan. So it's a win-win for those employees, because in effect, they are receiving 100% coverage by virtue of making that move. Employee communication is certainly becoming more and more critical to optimize healthcare utilization, as well as employees optimizing the resources offered by the health plans. That comes in a number of different forms, but just basic communication on the value of the employee establishing a relationship with a primary care physician, receiving or scheduling physical exams, recognizing or promoting the virtual medicine or urgent care or the CVS Minute clinics as more cost efficient and convenient places of care for a lot of different healthcare needs. Population health management comes into play, especially for our larger groups for whom we have claims data, and we can identify, for example, like I did just yesterday, during a visit to one of my nonprofits in DC, getting an understanding of the colorectal screening percentages, same with physical exams, breast screenings, etc. If we have data, of which we do, we can identify certain employee communication engagement strategies to promote the value importance of getting those screenings, or the importance of an employee or family member setting up an account with a virtual behavioral health provider within the network, or looking at EAP services, etc. Data analytics, I kind of referenced that. Retirement medical plan education. We're finding more and more of the aging population continuing to work and having reservations, quite frankly, of maybe wanting to or having a desire to maybe postpone retirement because they're a little bit leery about what kind of retirement plan solutions that are available to them. And so that's where the insurance benefits advisor contracts out or has internal resources and services, i.e. Medicare retirement specialists who conduct webinars or do on-site calls to help employees and their dependents understand and walk through different solutions. Voluntary benefits is becoming increasingly more important as a way to subsidize those deductibles. If employers are faced with the unfortunate reality of having to increase deductibles, there are voluntary benefit programs that employees can purchase at a fairly affordable amounts to subsidize those deductibles or higher copays. So I referenced a high deductible. I referenced the fact that employers are faced with increasing the need of increasing deductibles and copays. And we have found that many of our employers, many of our clients haven't had to go to this level as it relates to increasing the deductibles to the levels that are shown here, as well as factoring in layers of reimbursement accounts. But I think this is a good kind of case study on one of the clients that we work with, whereby they kept on getting increases year over year to the extent that they had kind of run out of room and had to basically pull that lever, representing as high a deductible as possible for the plan. And so what we have here is basically a three-part health plan design, whereby in gray, or part one, we have a high deductible base plan that features a $3,500 per individual and a $7,000 family deductible. And then for certain services, i.e. inpatient, outpatient, diagnostic, and x-rays, coinsurance comes into play. So after the deductible is satisfied, the plan requires that 35% of the costs beyond the deductible are shouldered by the employee. And as far as the doctor office visits, there's co-pays, but then a deductible of $3,500. Of course, I haven't found in my travels any nonprofit that would ever want to just offer this high deductible health plan to their employees on its own. That's why there's a part two in this case study, whereby the employee actually is only on the hook for the first $1,650 of the $3,500 deductible per individual, and the first $3,300 of the plan's $7,000 deductible. And then part three is where the medical expense reimbursement account comes into play, which the employer funds. And as you can see, that the employer funds via the MERP any dollar amounts in excess of the employee's net costs of $1,650 per individual and $3,300 per family. So what has made this approach financially attractive to this client is that the high deductible health plan resulted in, as you can imagine, a real low renewal premium, and they use those savings to fund the HRA. And so it has been a program that has happened to work for the employer from a financial standpoint, while at the same time, making the employees whole enough to the extent that they're only or relatively only shouldering the $1,650 per individual and $3,300 per family. And then to boot, to help further mitigate that $1,650 per individual, the employer in this case has contributed $500 in the health savings account that the employees can use to mitigate that $1,650. So I know there's a lot here though. And again, this is a strategy that basically shows the degree in which plan designs and funding options can be levered to get to perhaps a more financially attractive outcome than the more traditional plan design and finance options that be considered to date. As far as how it works for the employees, it's pretty straightforward. The client contracts out with a TPA that administers the MERP. The MERP administrator, the medical expense reimbursement plan administrator, issues a MasterCard that the employee uses to pay upfront for services that apply to their deductible, as well as the co-pays that they experience through the doctor office visits. As far as continuing our discussions on different strategies to explore and attempt to minimize costs, there is a continuum, as I mentioned earlier on the slide, of different financial options. And this slide kind of introduces you or provides you an overview of two types of alternative funding arrangements: a level funded arrangement and a self-funded arrangement with the stop loss. But to level set, I'll spend a little time just kind of talking through an insured plan, whereby in its purest sense, if you follow my cursor on the screen, you're going to see the cost components that make up an insured arrangement being fixed costs, as well as projected medical and prescription drug costs. And those two components make up the individual insured rate, as well as the family rate that the employer pays on a month in, month out basis to result in an annualized premium amount. right? And during that policy year, in the event claims are more than that which the carrier projected under the insured arrangement, then the insurance company is going to absorb those additional costs. In the event the employer has a year whereby claims are more favorable, the actual claims are more favorable than the projected claims that are built into the insured plan renewal, then the carrier is going to take the surplus. And so there's going to be the surpluses will not go back to the client. What I just explained to you was an insured arrangement to be contrasted by a level funded arrangement whereby there's two scenarios, financial scenarios that are demonstrated or shown here. One is where the employer pays a fixed amount of premiums, a level premium per individual, per family, month in, month out. So that's a fixed cost, a level funded cost, similar to your insured program scenario. However, and similar to an insured arrangement, in the event if claims are in excess of the level monthly premiums, which are represented by the orange part and the black part of this graph, the medical insurance carrier absorbs the loss. So the employer is not having to pay, the deficit in that instance. Whereas under a level funding arrangement, if there's a best case scenario whereby actual claims are less than projections, then the plan sponsor receives a refund equal to X percent. Usually it's 50%, sometimes 75% of whatever the claim surplus is. And this chart is showing that the actual medical paid claims are far less than that which were projected. And hence the combination of the green and the blue part of this chart represents the surplus, of which 50% is retained by the carrier and 50% is retained by the plan sponsor. And that's a financial reconciliation that is done at the close of the policy.
So Ken, talk a little bit about the stop loss insurance market, because I think in this left-hand column, that's a pretty key ingredient for the employer.
Yeah, thank you for that offer, John. Yeah, so in all of these different funding scenarios, but more importantly, the level funding and the self-funding, stop loss is a key element of the overall cost of a self-funded and a level funding arrangement. And what stop loss insurance does is it literally stops the losses for any one catastrophic claim in excess of, for example, of $100,000 of medical expenses paid during any given policy year. Any claims that in excess of that stop loss are absorbed by the stop loss carrier. Any claims up to that individual stop loss limit are absorbed by the client in a purely self-funded plan.
And are there a lot of stop loss carriers? Is it easy to get it? What's the relative cost? Just to give people, once again, don't spend
Yes,
20 minutes on it, but just give us kind of a,
yeah,
what's the market like and potential
sure,
costs?
sure. So it depends, okay, John, because well, first question, there's probably 12 plus different stop loss carriers that we as benefit brokers have access to. And we shop out stop loss renewals much the same as we shop out insurance renewals under a traditional insured arrangement. And stop loss renewals are going to also depend upon the underlying high cost claim cost specific and utilization specific to a given company. So again, there's some degree of volatility as it relates to that cost component of a self-funded program. So if I say, we do our best to kind of conduct market reviews, but getting back to your other question, it probably represents anywhere to 10, 7 to 15% of the overall spend.
Yeah. Okay, great. Thank you.
Yep. So as far as the self-funded with stop loss in its more purest form, in comparison to an insured arrangement or a level funded arrangement, it truly is a pay as you go type of proposition for our clients, in that the total annualized costs is broken down to the administrative costs expressed on a per employee per month basis, plus the stop loss insurance, which is also expressed on a per employee per month basis, and is paid to perhaps a stop loss carrier that is not the same as the name of the underlying plan administrator. For example, the underlying plan administrator could be a United, a Blue Cross Blue Shield of Massachusetts, and they're the ones processing the claims, collecting and billing, handling calls, wellness, etc. That's what the costs of those services are. And they may have a separate carve-out stop loss insurance carrier providing the stop loss insurance. And then you have but those two bands, the purple and the black, are paid month in, month out on a per employee per month basis by the carrier or by the employer. And then the variable, right, is the projected medical and pharmacy costs. So as claims are paid by the claims administrator, the Blue Cross Blue Shield, they turn around and request funds to cover for those costs. So it's a money in, money out kind of proposition. And then the other form of the stop loss, beyond just covering protection for catastrophic claims, the stop loss can also be arranged such that there's an element of umbrella insurance. So in other words, if claims are 125%, for example, uh, more or 25% more than that which is projected, then any claims that exceed that 125% threshold are reimbursed by the insurance carrier. So these are kind of the self-funding arrangements that can be explored on behalf of nonprofits. John, any other questions there?
Yeah, I got one. So Ken, before I met you, I was with a medium-sized retailer. We did self-funded for a year, and it was like playing with a roulette wheel. We never knew at times. We kind of knew the population, but we didn't know what health concerns were going to be.
Hmm.
I guess the self-funded, the employer must have a level of confidence about potentially what's going to happen. I'm just asking that question.
Yes, this is absolutely true, John, in the sense that if you're on an insured basis and you've got year over year ongoing claims that are resulting in large renewals, self-funding with stop loss may not be suitable for them. It is certainly more suitable for those certainly very large employers whose claims experience is more credible year in, year out, and whose claim projections can be, relatively more accurately projected by our in-house underwriters, to the extent that there's significant savings afforded to that type of plan sponsor, because usually The administrative costs are a lot less under this arrangement. They have greater flexibility to carve out the pharmacy benefit program to a pharmacy benefit manager, i.e. Caremark, CVS Caremark, or Express Scripts, or Optum, etc., under which they extract lots in the way of rebates and discounts.
Great, great, beautiful. Thank you.
So I won't get into a great deal more on the differences between self-funded and level funded, but suffice it to say, under a level funded arrangement, you're provided that much more in the way of claim reporting, whereas it's a black box under an insured arrangement. There's more in the way of underwriting. So to your point there, John, to assess whether or not level funding may be more financially appropriate versus an insured arrangement, one way to kind of vet that out is to follow the carrier's process of getting access to the health claims, understanding what the loss ratio is, and completing a general medical question to the best of the client's knowledge, all of which combined with the census that the client provides can provide carrier enough information to determine whether or not the level funded approach from a pricing standpoint is viable.
Great.
As far as alternative medical strategies, and this is in context too, as I mentioned at the beginning, some more relatively new alternative health insurance models, and they would follow two different brackets or two different types per this slide. One is an ICHRA, an individual contract health reimbursement arrangement, and their number of service providers is proliferating day in, day out. We here at Hub have a particular experience with Bavy, Zizzle, and the Big Plan. I will explain what an ICHRA is and how it works later on in the presentation. What you may be more aware of is the approach of contracting out with a PEO, a professional employment organization, that offers up health insurance and other benefits as part of their overall HR platform. And as you can see, there's a number of service providers there in that space: Insperity, TriNet, ADP, and Rippling. As far as the ICHRA goes, the best way that I think I can explain this from certainly an employee's perspective is that it's a Amazon.com like individual health insurance purchasing experience, whereby the employees can choose from multiple carriers, health insurance products, provider networks, limited versus broad, plan designs, high deductibles, relatively lower deductibles, HSA-based plans at different price points. And all those the offerings there, the options are all going to vary depending upon what state the employee resides in, because these are individual health insurance policies versus group policies. The individual policies are going to be written by the state that the employee resides in versus where the employer is situs from a group health insurance standpoint. And these rates are based on each employee's date of birth, their home zip code, and plan selection. So as such, the ICHRA can be a financial risk transfer play, to the extent that these individual rates are not based on what could be unfavorable claims experience of any one employee or specific to the group, as is the case under group insurance solutions or platforms. What I mean by that, if you recall in the former slide, I had a client, I have a client that's at 120% loss ratio, getting a 46% increase. And the big reason for that 46% increase is because under a group insurance contract, the employer's renewal rates for groups over 50 employees can largely be dependent upon their own claims versus premium loss ratio. Under an ICRA, there is can be greater budget and cost control against these high renewals because again, the rates are based off of the rates of the individual policy are based off the employee's date of birth, home zip code, and plan selection. Further,
Kent, one
yeah.
question. Just to clarify, you and I talked about this yesterday. So that top paragraph, employees can choose from the online benefit administration portal. So that would be Milliman Bavy saying, hey, we have 4 different potential options. It's not like the employee can go out and say, hey, I want to get this unique plan that's based in California. Part of it is it's already set up that they have a lot of choices, but it's only select choices. Am I saying that right?
No, it's a great question. And that last bullet point here for the attendees, to your point, the Milliman is an internationally, actuarial firm that has put up this Bavy platform, which is just that, an online platform and concierge service that streamlines employee plan selection, enrollment assistant, premium collection and payment, and premium deduction reporting. But getting to your question there, John, this platform has a prescribed, predetermined list of the carriers on their platform, of which each employee has access to allow for kind of a streamlined, more convenient consumer purchasing experience. With that said, in the state of Massachusetts, I can tell you that Bavy also allows for a more of a kind of administrative workaround that in the event an employee wants to enroll in a Blue Cross Blue Shield of Massachusetts plan, for example, that's not on the predetermined list of carriers on the Bavy platform, they can do that.
Interesting.
Yeah. And as far as the role that Milliman plays, they're an actuarial firm. They take the census that we provide them. They take the renewal, in this case, 49% increase that I referred to, and they put this through their own proprietary software that prices out what the collective premium is going to be for all the individual policies that employees would elect. That approximates the plan design product that is being renewed under a group plan and calculates the difference in overall premiums paid by the employer under the ICRA plan versus the traditional group plan renewal. So as to give the client a basis of understanding as to whether or not the ICRA is suitable for consideration.
And Kent, are employers using a more traditional plan and then offering ICRA as an option to employees, or is it, one size fits all? Where you got to give everybody the same option, or?
Yes. So to answer that question, you cannot offer the traditional group health plan along with an ICRA for any employee class. So in other words, any employees that are part of, a similarly situated group, i.e. a class, all have to be offered the ICRA, or all have to be offered the traditional group health insurance plan. However, with that said, if you have classes of employees that are well defined and distinguished from each other, i.e. maybe one group is in one state, the other is in another state, or you have a union versus non-union, etc., you can offer each different class or one class in ICRA and the other class a group traditional group health plan. That starts getting into some of the complexities of how ICRAs are regulated, John.
Yep. Great.
So these are types of plans, quite candidly, in New England, especially for larger groups, are not on a wholesale basis being adopted. It's been kind of a slow wait and see perspective, at least that I've personally found on the part of especially nonprofits. But with that said, clients, I think, would be behooved at least in having conversations with their benefit advisors to better understand what this is, how it works, how it could be impacted, how the financials employees can be impacted at the nonprofits.
Oh, great.
The last, should say non-traditional group health insurance plan strategy is the professional employment organization approach. As you folks may already well know, the PEO, they're an entity that provides the comprehensive, outsourced human resource solutions, notably mostly for small to mid-sized businesses that don't, at least that I find anyway, don't have the HR infrastructure to support, all and address the far-ranging complex compliance issues and HR functions that an otherwise larger employer is equipped to handle. But as part and parcel to the PEO offerings, they also include the ability for clients to purchase health insurance and other employee benefit programs, for that matter, within the PEO package. With that said, PEOs and Hub has corporate partnerships with many of them. Say that they are not wanting to be the carrier of last resort. So in other words, for those clients that are known to have spikes in their renewals, or they have large loss ratios, they, as in the PEOs, are going to individually underwrite them to determine whether or not they will be accepted in their pool. And that's what it is, the pool of employers that they manage year in, year out for purposes of developing renewal pricing. So I know, as an aside, there have been PEOs that, end up taking or bringing on a client and then come to find out the next year they are jacking up their rates. This is not to disparage the PEOs. It's just to point out that similar to the group health insurance market, there can be volatility specific to health insurance renewals.
So Kent, are the denial rates that high potentially?
Yes, they are. I have so just so you know, John, along those lines, hub, because we have access to all the PEO market, because we have access to all the ICHRA markets, and certainly we have access to all the traditional group health insurance carrier market. We're looked at as the kind of the single source through which our clients and prospective clients go to vet out all these different solutions in context to, what the nonprofit institutions, needs, interests, challenges, objectives are.
Great.
So I know I've talked about a lot of strategies that are available in the marketplace that probably has a lot of people's heads spinning. With that said, with the help of my team, which consists of a whole lot of different subject matter experts, including in-house underwriters, pharmacy benefit specialists, wellness experts, compliance slash attorneys, never mind, a terrific account service management team. We engage in our clients in a well thought out, mapped out, defined renewal management timeline that, as you can see, as it relates to this sample timeline, starts the first of the year. Or in other words, if we're going to the January 26th, once that renewal is over, we basically start at the beginning of the book, change that first page and go through what we would consider as being the appropriate times to engage on what types of topic matters to best keep our clients informed of the state of the market, how their plan is running, operationally as well as financially, to what extent is it meeting the needs of the clients, and mapping out a plan to best manage that renewal management process. And as you can see, at least on this renewal management timeline, it assumes that maybe the client does not have an HRA, doesn't have a MERP, doesn't have an HSA. They may be being first introduced to an ICHRA. So this is a timeline that basically includes a process of educating the nonprofit on the different health insurance management strategies that they should be aware of, what strikes a chord interest wise, and what kind of additional meetings we might have with the corresponding service providers to enhance that nonprofit's understanding.
And when Kent and I worked together, I don't know if I ever got the sheet here that there were 15 steps, but it was definitely a process. And the message was to stay engaged in the process because there were a lot of data points, claim cost, utilization, maybe some new plans. So part of it is it's very difficult to start in October and have a new plan start by the end of November. You've got to plan early and engage with someone like Kent. So good. Thanks, Kent.
To that point, John, as recent as it was that we worked with each other,
Yeah.
there weren't ICHRAs back then. For example, those just came about in 2020.
Yeah.
And in addition, there's been increasing interest on the part of alternative plan designs and financing mechanisms that come in the form of HRAs, MERPs, and HSAs, more than that have ever been seriously considered in the past due to escalating healthcare costs. Hence, the process of engaging and educating our clients is becoming that much more involved.
Yeah. Yeah. So Kent, we've got 15 minutes for some Q&A. So I appreciate the people that are still on the call that that have stuck with it. Kent knows I kind of study this as, I don't know, Kent, some kind of hobby thing or something. You know,
Yes, you're very
I'm
good.
still working it. Um, so put your questions in the chat, and then Kim will or Kent can just look at the questions.
Hmm.
I have a question for Leanna, who's the nonprofit center of the Berkshires. Is this something, I mean, we're going to send you the recording, but is this something would be benefit your members to get deeper into this?
You know, I don't, I'm not sure. The way that we've been approaching it, you know, it's obviously a huge issue. And it's killing the big guys and the small guys, the price increases. Um, there's been chat for a while about solutions. We haven't gotten into this type of uh, studying creative ways to, reduce costs, etc. But we've been advocating for a um, either policy changes or
Yeah.
wider solutions, perhaps from the state. Um, here in Massachusetts, we have the core 401k plan, which
Mm,
is run through the treasurer's office.
mm,
Um, Mass Municipal has 4,000 employees. Why isn't the nonprofit sector included in something like that? Or,
mm,
and obviously there are laws that prohibit risk pooling in Massachusetts. There's a lot of, you know, angles to this. But we are working on our own solution at this moment.
mm.
So,
Great.
um, I don't have all the details yet, but that's something, I mean, we've been working at this for years.
Yes.
That's great.
And we
That's
know
great.
there's some conversations in Boston as well. So I can't really speak to, and also, of course, to note that 75% of our nonprofits are small.
Yeah.
Mm,
So if their budgets are under 500,000, you're not looking at 50 or more employees, right? You're looking
Yeah.
at under that. So their options are limited. Um, yeah, so there's not that many nonprofits in Berkshire County that have more than 50 employees.
Great. No, great. Thanks. And I
Yeah,
guess
thank you very much for
maybe,
sharing that, Leanna. That's a
yeah.
great perspective and feedback, and we
Well, those
understand.
numbers are kind of universal, right? In the
Yeah,
United States,
yeah, right.
most nonprofits are small.
Mhm.
So it's a real problem. Um, so yeah, we're considered high risk for that reason, and that makes it difficult to negotiate. But yeah, so when I have more information about what we're trying to cook up, um,
Mm.
I'll certainly share pretty widely.
Terrific. Yeah, thank you so much. I'd love to, um, John, as I know John is, he's a real student of, healthcare and slash insurance, and he and I have great conversations. I'd love to, as you see fit, as appropriate, continue the dialogue in some way, shape, or form, because I love the whole, topic of healthcare delivery, financing, policy, administration, which I grant you is in a total state of chaos. You know.
So Megan, I hope I'm saying your name right. I know you're the uh, human resource manager of the nonprofit. Was this a valuable webinar for you?
Yeah, I definitely think so. Just giving us different options to explore. I don't know if any of them will be quite right for us, but we're always looking for ways to, cut down on costs. So it'll give us some avenues to go down for sure.
That's great. Yeah, no, that's the whole purpose of this program is introduce you to some concepts that could help you to manage or reduce your cost while improving coverage for employees. So, mission accomplished. Yeah, good, very
Yep.
good. Kim, any comments on your end?
Yeah, she did send a chat.
Is ICRA usually a good choice to offer more variety to save costs or both?
Yes. So the ICRA administrators really promote not just the potential for cost savings, but also offering up a lot more in the way of choice as far as carriers and products, plan designs, etc. Because you think about the group traditional health insurance market, those decisions as far as the carriers, plan designs, and price points in large part are made by the employers historically, which can be looked at as maybe more ideal or less ideal on the part of the employees and employers. In that employees, at least historically, may prefer to have their employers make the choice for them. Whereas maybe in a more consumer oriented type of employee, of which I have to believe the newer generation is kind of a part of, they like maybe more in the way of choice and not and are not put off and actually are prefer making selections online.
Good. I think we're at the end of our program.
Well, I learned some new things. Thank you. My
No,
eyes are a little glazed over.
no, it's,
because this is
listen,
way,
we're gonna
way
send you
beyond
a
me.
20-page quiz that you have to answer by 3 o'clock.
Right. Yeah, I appreciate that. Hopefully you took something away here and happy they have follow-up conversations to maybe may add clarity and
Yeah.
etc.
My feeling is if you did this webinar for some of our smaller nonprofits, you'd have to dumb it
Yeah.
down a bit.
Yeah.
You know what I mean? Like if you don't
Sure.
know the first thing about health insurance.
Yes.
And
Yeah.
I'm someone who's been not studying like John, but just trying to keep
Yeah.
up and deal with requests for assistance.
Yes.
But yes, ICRA had, wasn't really aware or on top of that. So, yeah, it'd have to be a lesser version of this,
Yes. Okay. Got it.
almost to introduce people to the concepts
Yeah.
generally, and then with maybe tips on for the smaller orgs, which way
Right.
they should, what of all the options they have, the creative
Yes.
strategies, which ones should they pursue if they have 50 and fewer employees, right?
Yeah. Got it. Got it. Thank you for sharing that. That's really helpful.
Okay. Well,
Yeah,
thank you
maybe
for sharing all of your knowledge, which is considerable.
Well,
And I'm sure there are people who, from the larger organizations, for whom this would have been super interesting. But like I said, we have so many small ones, so
yeah.
they're usually the ones reaching out.
Yeah.
When it comes to this, even though the big guys tell me they're getting killed. If you have 300
Yeah.
employees, it's just like
Right.
more
Yeah.
fundraising.
Yes,
More
exactly. That's
fundraising.
another webinar right there, John.
Yes,
Yeah,
yes.
yeah.
Anyway, but thank you so much, Kent, John.
Yeah.
Thank you for setting it up. Nice
Yeah.
to be with you today. And I do have a little break before my next meeting.
Oh boy.
Good.
Wow.
Terrific. Excellent. Well,
Well,
it's
Leanna, great
really nice to
idea.
meet you.
Great idea for, maybe an under 50 webinar that had more kind of the basics some options. So no, it's a good idea. I think part of it is, yeah, what is it? Like 80% of the nonprofits are under like $3 million in the US. So,
Yeah.
we got to think about maybe tailoring one
Yeah.
that addresses that sub marketplace. So great. No, Leanna,
Yes.
great suggestion.
Great.
And I owe
Thank
you a
you,
call.
guys.
I'll
Thank you
just
so
set up a
much.
time for a
Appreciate your
chat.
time.
Yeah. Okay. I'm going to stop there.